Okay, we've started now, and welcome to the people who I see are joining. We're going to wait just a couple minutes to give people time to join the webinar.
Se joindre au webinaire.
And then so we'll get started quite shortly. But thank you for those of you that are right now joining. I think this will be an interesting discussion about an interesting model for financing. Uh, SRHR health work in the Philippines, but potentially in other parts of the world. So I look forward to the presentation and to the discussion. You can see we've got a few more people joining. That's great. We'll give just one more minute. So just bear with me and then we'll launch in. Thank you to our two speakers on the other side of the world who it's the morning for us here. It's a bit later for you folks in the Philippines. So we appreciate that. Um, okay, I can see a number of people have joined. So I think we'll start, and if people are coming in, that'll be fine. So good morning, everybody. Thank you for joining today. My name is David Brewer. I'm Program Manager with Inter Pares, and I'm going to be moderating today's presentation and discussion. I'm speaking to you today from the unceded territory, unceded and unsurrendered Algonquin Anishinaabe territory, part of the Indigenous lands currently known as Canada. We are committed to building relationships with Indigenous-led justice movements and supporting connections between struggles in Canada and abroad. We welcome Indigenous resistance and resurgence as part of the colonizing process. A few logistical issues just to start. We are recording today's webinar so that we can share the content with others who are not able to be here today. Today's presentation will be in English, but there will be simultaneous interpretation for anyone who needs it. And so that we have the webinar available in French for sharing with others later. A big thanks in advance to our interpreters, Mike and Simon. Uh, if you require interpretation, please click on the globe at the bottom of your screen and select the language. Technical support today is Ashley Armstrong. She will put her email in the chat in case you need to contact her for any reason. We have with us today two speakers from the organization Likhaan Center for Women's Health in the Philippines. They'll be speaking today for about 15 minutes each as they outline the innovative funding system that Likhaan has developed, while at the same time being true to Likhaan's commitment to provide free, high-quality, respectful health services to women. Following their presentation, we hope that people will have questions and we can enter into a discussion on the challenges of sustainable funding for SRHR work.
Pour le
The
travail
first
de
speaker is going to be
SSR.
Ronit Susi, and she leads the Likhaan's finance unit. The second speaker is Alfredo, better known as June Melgar, and he currently leads the Monitoring, Evaluation, Adaptation, and Learning Unit of Likhaan, and he has led Likhaan's PhilHealth-based income strategy since 2016. So In the interest of time, we've put more complete bios for each of them that you can see in the chat. I want to start by giving a bit of background and setting the stage for where we are now. Inter Pares began its relationship with Likhaan when they were formed in 1995 and has continued that partnership ever since. Likhaan was working to provide sexual and reproductive health services to women in the poorest neighborhoods of Metro Manila. Their approach from the very beginning involved three elements. One, service delivery that was free and respectful and high quality. This was combined with the second element, outreach and education programs on SRHR in the same communities that drew in women as volunteer community health promoters and paid community health mobilizers. And they used this grassroots experience to carry out the third element, advocacy with local and national governments on laws and regulations related to SRHR. At that time, they operated small, informal clinics in the marginalized neighborhoods, and they helped women to organize local women's groups. Services were free, and it was paid for by the funding Likhaan received from international cooperation. In 2015, so 10 years ago, Inter Pares and Likhaan received funding from Global Affairs Canada for a project called Innovations in Reducing Maternal Mortality in the Philippines. And this project allowed Likhaan to formalize the clinics and obtain accreditation for them from PhilHealth, the National Insurance Program, and from DOH, the Department of Health. Being accredited allowed Likhaan to be reimbursed for some of the services that they provided in the clinics, and this began to generate revenue. The process of obtaining accreditation was documented, was shared with other like-minded groups. It was not an easy process, and it identified many obstacles. At the time, the only possibility for accreditation was a birthing clinic. The option of an accredited family planning clinic did not yet exist. At that time, revenue from PhilHealth was generated, but not enough to cover clinic operations, and with only some of the patients qualifying for reimbursements from PhilHealth. In 2019, Inter Pares obtained funding from Global Affairs Canada for a second project called Strategic Interventions to Build Momentum on Sexual and Reproductive Health. We called it BILMO because that title was a bit long. This project aimed to address one of the big challenges that Likhaan had identified in the first project. Adolescents were not coming to the clinics. They had great needs in the area of SRHR, but the existing model was not really meeting them, and the project addressed this in several ways. By this point, advocacy by Likhaan had resulted in a change in the regulation to allow for the accreditation of a family planning clinic. Family planning clinics were more economical than birthing clinics, more patients were qualifying for reimbursements, and more revenue was coming in, but still not enough to cover all of the operating costs. So that brings us to today. Now we have started a new 7-year project called Sustainable and Transformative Action to Realize SRHR, or better known as STARS. This project will expand the range of services that Likhaan provides in the clinics and strengthen the financial sustainability of the clinics based on this PhilHealth reimbursement system, in part by
en
improving the
partie en
process
améliorant
of
le processus
registration and
d'inscription.
enrolling PhilHealth. So that is a brief summary of how we've got to where we are today and what this webinar and the presentation by Ronith and June is going to address. There are 9 clinics in a network of clinics of Likhaan. 5 of them are supported by this STARS project. and the revenue is sufficient to cover part. The project is carried out in a very challenging global context. There are major cuts to international cooperation, and that's not just USAID, which made the front pages. There are many major northern donor countries implementing significant cuts to cooperation. And some of those funders have particularly targeted SRHR as an area for cuts. Over the past decade or more, the answer to shortfalls in aid funding, has been to put forward the private sector as a source of funds to fill the gap. This has been called innovative financing, blended financing, private sector funding. Please note that this is not the model for sustainable financing being presented here. So how does a Southern nonprofit organization ensure long-term financing for this kind of SRHR work? Is there a model to ensure financial self-sufficiency where aid funding is not needed? And that brings us to our presentation. Ronnie and June are going to present the model that Likhaan, with the help of Inter Pares and Global Affairs Canada, has developed over the past decade. I'd ask you to hold your questions until the end, unless it is a clarification, in which case I'd ask you to put that into the chat. And at this point, I'm now going to pass the microphone to Ronnie to begin the presentation.
Hello. I'll just check if you're seeing my screen.
Yes, we do.
Okay. Uh, Thanks, David, for setting the context. And thanks, everyone, for joining us today. We'd like to share a practical question in global health financing. Where does the money came from and where does it actually go? We'll explore this through a case study from our own experience at Likhaan in the Philippines, looking at how nonprofit sexual and reproductive health or SRH clinic works with PhilHealth, the National Health Insurance System, and what this relationship means for funding our clinic operations. I'll start with the main takeaway. First, more than half of Likhaan SRH clinic costs can already be covered by existing PhilHealth payments. Second, few policy changes are needed to close the remaining gap. And third, nonprofits are not just passive recipients of health financing. We can and we should actively contest and shape the resources and policy space of social health insurance. As David mentioned, Likhaan currently operates 9 SRH clinics, 5 of which are supported by GAC under the STARS project. Location is a core part of our strategy. We don't wait for patients to come to us in the city-centered. Instead, we deliberately place our clinic in dense urban communities in Metro Manila, in relocation sites for evicted families, and in rural underserved areas like Eastern Samar. These are communities where the formal health system is often limited or absent and need for quality services. This is a dense urban poor community in Tondo, Manila, and this is also where Likhaan works. Families live in tightly packed homes along narrow alleys, and despite being in city, poverty and overcrowding make access to quality healthcare limited. This is a rural poor and disaster-prone community in Eastern Samar, and this is also where Likhan's community. Homes are scattered and services are far away. Transportation costs and weak health infrastructure make services difficult to access. A standard Likhaan clinics is run by small, multidisciplinary team. And importantly, this is not necessarily led by a medical doctor. Most clinics are staffed by 2 clinicians, either nurses or midwife, supported by a medical clerk, a clinic aide, a clinic utility driver, to community organizers. The community organizers are important. They conduct educational sessions, help women navigate the health system, address misinformation and fear. However, PhilHealth does not pay for the community organizing, even though it directly improves health outcomes. To be eligible for public funding, we maintain strict standards. Out of our 9 clinics, 8 are already registered and accredited both with the Department of Health and the PhilHealth, and 1 is still in the processing of licensing. Under PhilHealth rules, only 2 services, implant and IUD insertion, are currently reimbursable for freestanding family planning clinics. But it's important to be clear, this type of accreditation does not limit what services we are allowed to provide. As health providers, we are allowed to provide full spectrum of SRH care. So beyond family planning, our clinics also provide STI management, cervical cancer screening, and counseling for survivor of sexual and gender-based violence. Even, even if PhilHealth does not yet pay for these services. Now, let's look at the financial impact of this strategy, what we analyze and what we are measuring. The annual income for the last 5 fiscal year, and we'll compare this into 2 ways. First, we'll compare the PhilHealth income to our total operating costs. This include health services, community organizing, and share in the administrative or overhead costs. Second, we'll look at the PhilHealth income compared only to our health services and admin costs, focusing strictly on service delivery. This graph shows a clear upward linear trend. In 2020 and 2021 fiscal year, our PhilHealth income was roughly 11.78 million pesos or 270,000 Canadian dollar. By current 2025 and 2026 period, the figure has more than doubled to over 26 million peso or 610,000 Canadian dollar. This represents a significant shift toward financial sustainability of our clinic operations. Before we look at the percentages in the next slide, it's important to be clear what we meant by cost. This diagram shows how Likhaan program costs are structured. When we refer to health costs plus community cost, we're talking about the actual costs of running clinics in the ground. This include all field clinic staff, rent, supplies, and other day-to-day operating expenses, plus a proportion of share of central overhead and administrative cost. What we intentionally exclude is here are the advocacy, fundraising, and other similar activities because they are not directly tied to clinical service delivery. Clarifying this distinction helps make the percentages in the next slide easier and fairer to interpret. So this slide shows PhilHealth income as proportion of health, community organizing, and admin cost. The green bars shows the PhilHealth income, which I've previously discussed, steadily increasing over time, while the red line shows how much of the cost it actually covers. In the early years, PhilHealth covered about 1/3 of this cost. After some fluctuation, coverage rises sharply in 2023-2024. By 2024 and 2025, PhilHealth is covering more than 60% of this cost, showing that it has become a major source of funding for Likhaan clinics. In this slide, we narrow the focus even further. Here, we exclude the community cost and advocacy cost because these are not funded by PhilHealth. What we left here is the health cost. these are directly tied to delivering clinical services. This gives us a clearer picture of how well PhilHealth is actually covering the core costs of running clinics. Once we exclude the community organizing and look just at the health and admin costs, the picture changes significantly. PhilHealth covers about 40 to 50% of this cost in the early years. This rises quickly after 2023. By 2024 and 2025, PhilHealth is covering more than 80% of core clinic costs. By looking at PhilHealth income as proportion of the health and admin costs, we can see how close we are to fully financing clinical services through social health insurance, even though gap there's still a gap remains. Looking ahead, the direction is clearly positive. In January 2025, PhilHealth increased reimbursement rates by 50%, and there is a strong public pressure for further benefit expansion. Because of this, we expect both the amount and the proportion of the cost covered by the PhilHealth to continue grow over the next 1 to 2 years before naturally leveling off. This reinforces a key point of the presentation. Social health insurance is already financing a large share of nonprofit SRH services. And with the right policy reforms, it can do even more. And for now, that is the end of my part. I will now pass the presentation to Tito June, who will take us through the social and operational context in the next session. Thank you.
Thank you, Ronnie. So June, we'll turn it over to you. I think you're muted, June.
Okay.
Yes, now we have.
Okay. I will discuss 4 topics surrounding our health financing experience. We can think of them as social context, the operational context, current issues, and lessons. For the social context, we frequently have this question thrown at us: why provide services? Why not simply lobby the government for better services and policies? In this section, I'll cover the gender and class issues that drive Likhaan's thinking and approach. These are presidents of the Philippines. SRH and women's rights are presidential level controversies here in the country. They are taboo and contested in our majority Catholic country. In 1987, a new provision was lobbied into our constitution. It says, the state shall equally protect the life of the mother and the life of the unborn from conception. Since then, this has triggered tenacious actions to ban IUDs, hormonal methods, over supposed abortion mechanisms. From 2001 to 2010, the president nearly dismantled the national FP program. She ordered a focus on church-approved natural family planning. During this period, modern FP was banned in Manila's facilities by a mayor who also headed pro-life Philippines. The president defended him, stating that it was the mayor's right to have a pro-life policy in his locality. In January of last year, the current president felt compelled to denounce the woke and abhorrent elements of a teen pregnancy prevention bill. So in the Philippines, leaving SRH services and education entirely in government hands is both unwise and unsafe. Due to this top-level tug-of-wars, our country suffers from failing SRH indicators. Take the indicator demand for FP satisfied by modern methods. North America, the world, Southeast Asia, they're all ahead of us. We're just at 58%, the same level as sub-Saharan Africa. We are also behind in other areas such as maternal mortality, HIV, and cervical cancer prevention. When public SRH programs are weak or deliberately weakened, marginalized women bear the consequences. For example, unplanned pregnancies further strain underfunded maternal clinics and hospitals. Many do not get served at all. Among the poorest women, 24 to 26% do not receive antenatal or postnatal care, 5 times that of the wealthiest. Uh, in pregnancy, 6 times higher in the poorest households compared to the wealthiest. As we gained more PhilHealth experience, we uncovered discriminatory policies that largely impact marginalized women. Our PhilHealth approach became more important. Real-life evidence can fuel advocacy for change. I'll show 2 examples. First, the self-employed contribute twice, their own share and a fictional employer's share, unless they register annually as financially incapable. Because women must often balance paid work with child and home care, they are largely the face of the self-employed. Second, PhilHealth rules discriminate against cohabiting partners. While a child can be a dependent beneficiary regardless of the parent's marital status, the live-in partner cannot. A common scenario is as follows. A working father with PhilHealth can include the young child as a dependent, but cannot include his partner caring for that child. The woman must separately register as a member with no capacity to pay, as her domestic work is unpaid. When the policy began in 1995, less than 10% of births were to unmarried women. This has since grown dramatically. It is now at 60%, a majority since 2015. To summarize, Likhaan provides services and education because these are taboo and contested. It is unwise and unsafe to leave them entirely to the government and simply do advocacy. Marginalized women need better services now. This is a critical demand in the poor communities where we work. Discriminatory policies exist. Providing services and navigating the system can effectively expose them. Second part, the operational context. What is PhilHealth? Why top PhilHealth? And why just now? Why not in 1995? PhilHealth is a government body managing the social health insurance program. Will cover 3 main functions: pooling, accreditation, and disbursement. PhilHealth pools public funds. It has the only unfragmented health fund in our country today. It is comprised of mandatory contributions from financially capable members, employers' contributions, mandatory also, national taxes to subsidize marginalized groups, shares from legal lotto and gambling, and investment income from reserve funds. PhilHealth accredits both health facilities and medical staff. Providers must pass an assessment and undergo regular renewals. Facilities include hospitals, clinics, and pharmacies. They are owned by the national or local government and private, for-profit, or non-profit entities. Disbursements go to facilities. The primary mode is reimbursement. Facilities absorb the initial cost, bill PhilHealth within 60 days, and ideally receive payment within another 60 days. PhilHealth sets a cap for each illness or treatment. For example, a maternity care package is capped at 15,600 pesos or Canadian $364, covering antenatal visits, normal delivery, and postnatal care, all in. Bills beyond the cap are paid for, if available, by facility funds, by HMOs or private insurance, or paid out of pocket if there's nothing else. Facility funds can be tax allotments if they are in government facilities, grants and donations in nonprofit facilities, and charity funds in for-profit facilities. In 2024, PhilHealth paid 164 billion pesos or Canadian $3.8 billion in benefits. This is 11% of 2024's health expenditures, which is quite low compared to the 43% out-of-pocket spending by patients. But of course, 164 billion is extremely high compared to the resources of nonprofits. So why tap PhilHealth for health funding? One key factor is its rule-based system. Since it was founded in 1995, the participation of private healthcare providers, including nonprofit NGOs, have been based on written regulations. Comparing this with alternatives emphasize the benefits of a rule-based system. While the Department of Health provides NGOs with family planning supplies, the amount and timing are often unpredictable. More importantly, DOH typically excludes funding for staff salaries and operations. Local governments and legislators in Congress can also mobilize funds for health services. However, these budgets are often subject to political discretion. This creates a high risk for NGOs to get entangled in partisan politics or, in some cases, corruption. Even with a rule-based system, PhilHealth had a weak impact on the marginalized
sur les
sectors
pauvres
prior
et les
to 2012.
marginalisés avant 2012.
In 1995, when
Deux facteurs
PhilHealth
majeurs
got formed,
expliquent cette
local governments got tasked with picking subsidized persons and paying for their contributions. This gave the rise to the quote-unquote politically poor, where subsidies depended on political patronage rather than actual need. Second, the law restricted subsidies to the poorest of the poor, the so-called indigents, defined as those with no visible means of income or in a below subsistence level of living. Consequently, the working class poor and other marginalized groups were excluded from these subsidies. In 2012, a law was passed earmarking tax shares to PhilHealth. In 2013, with financing secured, the selection and funding of subsidized persons were transferred to the national government. So from local, it got to be a national responsibility. In later years, several laws have expanded subsidies to include special groups such as domestic workers, senior citizens, persons with disabilities, and solo parents. In 2019, two laws finally expanded the income-based criteria for subsidies. So both financial incapacity to pay contribution and incapacity to pay for severe illnesses, the so-called catastrophic cases, are now accepted as criteria for subsidies. So it's not the indigents, it's not just the indigents anymore. From 2014 onwards, we began evaluating PhilHealth accreditation. We explored several options, but each had significant barriers. We explored the infirmary as with MSF as our main donor. This was even before the GAC project. However, we quickly realized that the standards were prohibitive. As defined by the DOH, an infirmary is essentially a small hospital with no operating room. So we backed off. We also looked into ambulatory surgical clinics. Since a partner NGO ran them for tubal ligation and vasectomies. However, we found out that the requirements had been raised and they were actually having difficulty relicensing. On top of that, getting surgeons into NGO work seemed too difficult to even try for. Finally, we settled on birthing clinics, and this is the one funded by Global Affairs Canada and Inter Pares, and successfully accredited 3 of them. We eventually learned, however, that income from maternity services were too low compared to the staff time used. In contrast, FP services generated much higher income. So in 2016, applying the past lessons, Likhaan proposed to the DOH and PhilHealth a simpler type of health facility, the freestanding family planning clinic. After policy drafts and discussions, this was approved by the DOH in 2017 and PhilHealth in 2018. The FP clinic offered simpler staffing and facility requirements, allowed a 5-day, 8 to 5 schedule, paid for certain FP procedures while recognizing other SRH services, even those unpaid by PhilHealth if done at that facility. So, what's the current situation? We now tackle the current issues in this health financing approach. For us, there are 2 primary concerns. First, the remaining gap between income and cost. And second, the discriminatory rules that limit access and use. Fundraising remains a vital strategy to address the funding gap. Given that Likhaan serves marginalized communities, soliciting support from donors rather than resorting to co-payments, which is the formula of PhilHealth. They say private entities can just do co-payments. Soliciting donors remains an ethical and viable approach, we think. And the rest is policy advocacy, which dominates the other options. We may be entering a phase where structural issues must be addressed to achieve further progress in sustainability. For instance, as an advocacy agenda, primary care must be given higher priority than before. Under this agenda, PhilHealth should pay for more SRH services in basic clinics, STI, cervical cancer prevention, ANC, SGBV, and others, as supported by existing safety and efficacy evidence. In addition, payment levels should match costs and equity issues, especially for nonprofit clinics that waive co-payments. On discriminatory rules, viable alternatives are actually available and done by other countries. For instance, the government could subsidize the employer's share for self-employed individuals or waive it entirely to create equality with formal workers. To include live-in partners, PhilHealth could permit the declaration of one domestic partner regardless of marital status. Last, to summarize this presentation, 3 lessons stand out, I think. On the role of nonprofit health NGOs, we can and should actively contest social health insurance resources. In our interactions with fundraising trainers and trainees, this often appears to be a blind spot for them. They are not really aware of it. It should therefore be more actively promoted. On financial sustainability, achieving a break-even point is within reach, but hard or structural problems remain. We must pursue multiple policy reforms that enhance access and sustainability. Even if one of them succeeds, then that will be good for sustainability, while at the same time strengthening our fundraising efforts. And last, policy advocacies are far more effective when backed by hands-on experience in health and community services. Building PhilHealth revenue from zero, we started at zero, required a combination of health services, community organizing, and policy work. This ends our presentation. Thank you.
Thank you so much, June and Ronnie. That was a really comprehensive presentation of a very innovative model that you've been working on for 10 years now. Um, it's a model that is in contrast to the for-profit private medical care that's available in the country. And I mean, to be clear, after somebody who has visited the Philippines, if you've got money, you can get the best medical care in the world. But you've got to have a lot of money. And if you don't, and you live in the marginalized neighborhoods that Likhaan is working in, then the public health care that is available to you is uh, not quite so good. Um, but I think as a starting point for our discussion here, I want to say that we, as Inter Pares, as the partner of Likhaan and collaborator in this, we believe that the state has a responsibility to provide health care to all of its citizens without respect to their ability to pay for it. That is what we have in Canada. That's what we've defended for years in Canada. Um, my colleague Rita, who's somewhere in that list of participants, is part of the Canadian Health Coalition, and that is what they do, is defend public health care. Um, so I think that for us has to be the starting point that healthcare has to be free and available to all citizens. Um, I'm going to open it up to now to discussion and comments from people. Um, there are a couple questions. There was one question put in the chat during the presentation, which was just to, could you give us an idea of how many patients attend the Likhaan, or you are attending to via the Likhaan clinics, just to get an idea of the scale, for example, in 2025. Uh,
Yes, David, I will take on that. For 2024 to 2025, Likhaan served approximately 45,000 patients, 31% of whom came from contraceptive injectable services, and 17% for implant insertion, 12% for contraceptive pills, and only 2% for IUD insertion. But 90% of our services of our clients are for family planning services.
okay. So a very large number of people, 45,000. Uh, so let me start off then and say, because I remember this discussion from 10 years ago when we started the MNCH project. Uh, you're creating a network of clinics where you've got uh, high quality reproductive health services available to people who don't get that when they go to the state services. They either get charged illegally, they get treated badly, they are asked to pay. Um, they also don't do the outreach and education work that combines with the service delivery that you do. So you've created this model. You've created a model for generating income from it, but you also you've currently got 9 clinics to satisfy the demand in the Philippines. You'd probably need, I don't know, 10,000 clinics, maybe
No, no, no.
some very large number. Um, and I remember asking you, June, at the time, is that the future that you see for Likhaan? Do you want to have a huge network of clinics? Um,
Well, for sexual and reproductive health, we do argue that we need nonprofits to be in it, an integral part of it, because of the characteristics of the country, where SRH When we get a new administration, it may not be a friendly administration to these types of services. Then we can get problems of partial restrictions or full restrictions or bans. So we do need backup plans in those type of situation. And even now, as you point out, we do need facilities that can do good service, but we cannot, and we do not intend to replace government. That will be well. What we think is to direct policies towards more access, more good quality service, and things like that to help in that direction. Not to replace government with the services that they do need to provide. They do have the scale to do it.
Okay. I'm going to ask, there's a question in the chat, but I'm going to ask one quick follow-up question to that, which is the model that you've got, is it replicable? Could you take it to allies who are working with you to promote SRHR in the Philippines and have other NGOs, other civil society organizations set up clinics? So you don't run a huge network of clinics, but other people do, and other people can respond in other parts of the Philippines in the same way that you are in Metro Manila and East Samar.
Yes, I think some will be interested. When we started this, frankly, I was saying to myself that if we ever reached 70%, the 30%, we can do fundraising on that. Or if we reach 80%, the 20% we can do fundraising on. So I think like-minded nonprofits also think that way. It's not that you replace your entire income stream with PhilHealth, but you add on PhilHealth as a major backbone of your income stream. And then we also have that option of fighting for more policy reforms because right now PhilHealth pays just two services of the maybe six services that we do. They pay just two. So if they can pay more, that will give us more room to be financially sustainable. And also the rates of the payment that they provide. That's also one issue that we have. It's too low. They treat us like the same way as for-profit enterprises, where the solution to that problem will be to just charge co-payment, and we refuse to do that.
Okay. I'm going to read out a question from Maggie Singh saying, thank you for sharing your experience, which is very inspiring. Can you share specifically a few key factors that contribute to the growth and success of your SRHR services for marginalized groups, especially adolescent groups, while facing ongoing challenges from political policy, cultural aspects such as pro-life policy and norms? So a few factors that have contributed to the growth and success of.
I think a key part is community work. So we don't just operate clinics, we do community organizing, education, and all that integrated parts of community work. And also combining both with policy reforms, policy advocacy. So as you mentioned in your introduction, that's I think what's unique with how Likhaan works. We try to integrate three parts uh, of work of efforts: clinical services, community organizing, and advocacy. In some years, we were stressing advocacy. In some years, clinical work. It's really it depends on the situation, but we we have been committed from the beginning to integrate those three parts of it.
Hmm. It's interesting because I think that has actually kind of addressed the next question here in the chat, which was how do you balance and coordinate your work in SRHR service, education, and advocacy? How does each part of the work strengthen one another, re the quality of work and the impact, including the financial sustainability?
Well, as described in the presentation, we learned uh, about financial costs and income and all those stuff by doing service work. Otherwise, we will just be studying the experience of others, and there may not be non-profit services to study. So we will be forced to study for-profit enterprises, and that will be
Right.
not a good place to study those types of issues. So I think each component of the work strengthens the other one, because like when we we we, we are part of a coordinating body with the DOH called the National Implementation Team for the Reproductive Health Law. So when we speak there, our representatives speak there, we speak from experience, and that's the advantage of having practical work in delivering health services. Otherwise, you will just be someone who is trying out ideas, and they can just brush you off. So those two together, I think they're clearly interrelated. Now, with regards to community organizing work, when we were uh, fighting for a law that protects reproductive health, we had to rely on community support to mobilize people to show that uh, the conservative forces opposing reproductive health, they are really in the minority, and you need to show that publicly, and you need community organizings, alliance work to do that. Otherwise, you will just be a minority voice, yeah, in those
Mhm.
debates.
There, I'm going to combine two questions here. One again from Maggie and another one from Rita. Um, so Maggie's question was, do you work and engage with religious leaders? If so, any experience and lessons learned? And Rita's asking, is the social context becoming more favorable to SRHR or the reverse? Is this a matter of a generational change? Are young people more liberal and receptive?
I'll give the question on young people to Ronit. You want to take that on, Ronit?
You can take it with me.
Okay, I'll
Right.
answer first the question on religious
Okay.
advocacy with the religious groups. We did, and we had some ties with them because not the Catholic Church is not a monolithic group. So
Hmm.
some during the reproductive health law debates, one group of uh, professors from a Catholic university actually initiated a petition to say that Catholics in good faith can support the reproductive health bill. And that actually, during that time, it was sort of like a tipping point for support for the bill. When those people came out with that very public, very clear statement, and they were actually threatened by some in their school to be kicked out, and that created more problems for the other side. So
Hmm.
it's good to link up with the religious groups, and you should not treat religions and religious groups as a monolith.
Uh, so the first part of Rita's question was the social context. Is it more favorable? So, uh, are the
Not
religious groups
not sure.
more powerful, or would you say they are over time losing influence and power? How do you
Well,
find?
right now we have many other social issues at hand in the country, so that may be
Hmm.
just the situation. So this type of debates are not in the headlines right now. But
Hmm.
I'm not sure if it is an indication of their weakness. We did have a strong campaign from them on opposing the CSE, a comprehensive sexuality education bill
Hmm.
with some regulations or uh, liberalization of policy on adolescents accessing family planning and reproductive health services. So it was on liberalizing the parental consent concept, but the this conservative group zeroed in on the comprehensive sexuality education part of it, and we actually got hammered during that time. And that was the time when the current president uh, came out with a statement saying he was surprised with the woke and abhorrent content of that bill.
Yeah. Oh dear. So, Ronnie, what about the
Yes.
question of younger people? Do you see a change in attitudes in
Well, what we see currently, we have hired like 10 new young advocates. So they are more open on when it comes to traditionally been considered taboo. So during their interview, we are surprised that they are more liberate and very receptive. And we also have a project like we have created young CHP youth volunteers who discussed the issues with their peers. So, and
Hmm.
personally, I came from a very conservative family, but through Likhaan, I'm now more liberal and likely empowered.
Mhm. Okay. So you're optimistic. That's great. That's um, one of the one of the things that has happened in the Philippines is a universal health care law. Um, and so what does that legislation say with respect to SRHR and how is that is that going to have any impact on the financial questions that we've been discussing?
Nothing really on SRHR. It's a general health law which focuses on financing. We have some problems with the law. It was rushed, and some parts were not carefully written. But some good provisions came out of it. Like one which helps us in our field health work is they separated the concept of getting benefits from paying for it. So now those are paying for the contributions. So now those are separate pathways. Like you're automatically granted benefits even if you have arrears in field health.
Hmm.
So that's one that's positive, and we got uh, some advantage, yeah, in that regard, because before field health was checking if you had paid 6 out of the last 9 months. They had rules like that, and you
Hmm.
have to they have to check or the data is not available, things like that.
So in the new project, that whole question of are people um, registered with PhilHealth and therefore are they eligible to have the service reimbursed. I know that was a huge problem at the beginning when we started the MNCH project back in 2015. I forget what the percentage was, but a huge percentage of the patients that came to the clinics, you were providing all the treatment, but there was really no possibility of getting any reimbursement from PhilHealth. Is
So
that,
that's part of the benefit of the UHC law that I was talking about.
yeah.
That they separated the question of getting benefits from the question of paying your contributions. Of course,
Hmm.
people must still be registered as members, but that's a fairly easy thing to do. Now, the key question right now is that's part of our advocacy. You have two types of registration. You can register as a paying member, or you can register as a subsidized member, non-paying. And there are income rules, situation rules where we have to teach people how qualified they are for subsidies
Hmm.
and what they should do to be subsidized. Because most people in the communities we serve are actually qualified for subsidies. They just don't know how to go about being subsidized. The rules need to be simpler and they need assistance in that regard.
Hmm.
In some respect, they need signatures from medical social workers to certify that they are indeed qualified for subsidies.
Hmm. And so this is part of the work of the outreach and education that you're doing in
Yes.
the communities along with the service provision. Okay. I know that the advocacy is hard. Um, I wanted to recount when I started, when we started in 2015, and most of the revenue was coming from the insertion of contraceptive implants, from the reimbursements. At that point, you said to me, well, the odd thing is that they pay us to put in to insert the contraceptive implant, but nobody seems to want to pay to take it out again. Um, and in 2015, you said, but we're working on it. We're doing advocacy and we're pretty sure because the doctors want this, there will be a reimbursement for the removal of the implant. So we're 10 years later. What's the situation?
Well, I think actually the solution came in the form of increasing the payment for insertion. So now we
Hmm.
are quite satisfied with the rate that they are paying for implant insertion that we say, well, for us, it can cover removal. Now, our problem right now is not the payment itself, but other facilities, especially government facilities, referring patients to us for removal because apparently some of their staff are not trained on how to remove implants. They've been trained to insert but not trained to remove. Or in some cases, they're referring to private physicians who charge a few thousand pesos for removal. When in fact, removal procedure is done in 5 minutes, 10 minutes. It's as simple as that. So we are happy with the rates that they are paying with insertion. It can cover removal. The problem is not everyone is doing removals, and we are getting referrals from people who do
Yeah.
not know how to remove it.
Okay. So in theory, some other doctor is being paid quite well to
Yes,
to insert the
but
contraceptive implant and to remove it, but they just don't want to do the removals.
yes, that's the current problem.
Okay. Um, so we've talked about the importance of the education and outreach that Likhaan does, and that you've talked about a network of community health promoters who are volunteers from the communities and community organizers or mobilizers who are paid staff, but again, people who've come from the communities. Um, and we've talked a little bit, I think it's been mentioned that there are local groups, groups of youth, groups of women. I'm wondering if can you describe those community groups and how you engage with them and just flesh out a bit that part of the work that you're doing because it seems so important to the advocacy and to making sure the service delivery is working the way it should work.
We do two approaches. One is volunteer networks, so we call them community health promoters. They are volunteers and they network with Likhaan community organizers or community mobilizers that are paid staff. The other approach is to uh, organize through organizations, through community-based organizations, whether they're existing or new organizations. Some of them self-organize, some with our help. They elect their own leaders, their own officers, their own do their own programs and link with us. So that's the other approach. We combine both and try to do well focus on doing education work with leaders and volunteers who want to reach out to others. So those
Mhm.
those are the two approaches we do.
And those uh, local women's groups and youth groups, LGBTQ plus groups are brought together in a sort of association or federation of look through PLAC. No?
PLAC and some other organizations. Like I think Ronit has participated in local in the port area. So what do
Um,
they call their can you narrate that association or alliance that they're building there?
It's a network of NGO near the Parola. It's called Parola Interagency Network, wherein all NGOs around that area were come together to to provide and share our services. Like there were NGOs for educations, safety, environment, and health. So we
So
also
we do
have
the health part.
Yes, we do the health part, especially the family planning, and also other health sector also provide general medicine, especially for nutrition, and also some government like the DSWD, the Social Work Department of the Manila government is also sitting in that network.
So there's a
So
lot.
basically, we
Mhm.
do our own effort and also participate in efforts of others.
Mhm. So we're getting sort of closer to the end of time. I don't if people have more questions, please feel free to put them into either the chat or the question and answer box. I I guess I wanted to ask if you I asked you before, do you think that other CSOs could take up this model? And you said, yeah, and there has been some interest and you've explored that option, and I know that's part of the STARS project. Is this a model that you could see in any country that has a public health insurance policy? I mean, oh,
As long as the insurance policy accepts participation from private practitioners
hmm,
um, that may encompass non-profit private practitioners. I
hmm,
think it's a possibility, and I'm not sure if that's the common setup of social health insurance in countries, or they are just funding their own government staff social health insurance. I'm not sure,
hmm.
but
Okay.
if there's space for private providers and nonprofits can enter that space, then I think it's worth fighting for that space.
Hmm. It seems to me that it would, well, sorry, I was getting, was somebody trying to ask a question or no? Okay. I don't know what that was. I heard noise in the background there. Um, I mean, that would be interesting in a future discussion to explore. How is it possible to replicate this model in other countries that have uh, public health insurance programs and that might accept civil society organizations, nonprofits working? This also in the Philippines applies to for-profit organizations, right? I mean, if
Well,
you were if you were a for-profit family planning clinic, you could set yourself up and
yes, but there like we know of uh, some organizations that are for profit and they are now into clinics in malls, and their target clientele are
Mhm.
basically the upper middle class, and they are actually advertising their prices, and we are quite surprised by the prices that they are charging. Like for implant insertion, I think they're charging 10 or 12,000 in. That's double
Wow.
what PhilHealth is paying. So they get funds from PhilHealth, and then at the same time ask
There.
for co-payment from their clients. So that's really too much.
Wow. So you're receiving 6,000 pesos as the
Five five, I think.
five
5 5.
for the
Then for the for-profit facilities, they charge. I We heard one OBGYN board member of ours who said, I think they're charging, the practice now is charging 14 or 15,000 pesos for implant insertion. And that's,
and they would get the PhilHealth reimbursement on
yes,
top of that.
yes.
Wow.
Wow.
Uh,
So
okay.
it's difficult. It's real difficult communicating with them or even studying their cost or whatnot. But
Yeah.
they they target those types of clients who will pay that much.
Does okay, is it difficult then? Um, I mean, if for the same services they could make four times the revenue that you're making, um, or that I know that's a rough calculation, would they then pay their staff four times what you're paying your staff? Or would,
No.
I mean, it do
maybe
you?
maybe the malls, the
Yeah,
rental for the malls, but I
yeah,
don't know really.
okay.
But they do publicize their prices, so I'm quite
Yeah.
surprised with
I
prices
guess
that they're.
where I'm going with that question is, do you have issues around maintaining staff because staff can go from Likhaan and then go to a private for-profit family planning clinic and presumably at least their revenue is much higher than yours. So maybe their
I, I
salaries are much higher than yours.
I think Ronit is best positioned to answer that. Okay, go
Okay.
ahead, Ronit.
What our biggest competitor right now is the government because their raises their salary grade for nurses. It's like 40,000 their entry level. So it's much higher than our current salary grade. But for private hospital, we're still above their entry level rate. So but right now our attrition rate is for clinician is currently we don't lose it's like only one clinician has been moved to another organization in the last year, but we're of course Likhaan is considering we are we are restructuring our pay scale also to cope up at least with the competitive. But we cannot afford the government rates for
Mm-hmm.
now.
No, okay. Um, there's another question here asking about the percent. What is the percentage of GAC funding in your organization's budget? Do you get funding support from other donors? Just curious on your organization's funding sources for your operations.
Yeah, in the current fiscal year, GAC is one of our major funder, which is approximately 20% of our funds. We also have funds from other nonprofit international NGO like the Manan Trust, Kaduri Foundation, and recently we have been awarded as one of the awardee in Action for Women's Health funded by Pivotal by Melinda French Gates. So, and also we have growing individual donors.
Well, congratulations on the Melinda French Gates the award. That was amazing. Um, has Likhaan suffered from the demise of USAID, or as I referred in my introductory remarks, it's not only USAID that has cut back on international cooperation. Are you seeing that as Likhaan or hearing about it within the sector, the cuts in aid?
Yeah, yes, because we have an alliance called Reproductive Health Advocacy Network, and some members of that alliance are being funded by USAID. But us, Likhan, we do not have any. We have not had and do not have any projects with USAID. But we do feel the impact. Like there's a question on who will continue maintaining the data in NDHS, the DHS surveys, because the Philippine government relies heavily on data from that survey, and that survey, I think now it's delayed because of lack of funding from USAID.
Okay. I I think I don't see any more questions in the chat or the question and answer. Um, we're getting close to the end of the time. I wanted to uh, give Alec from Global Affairs Canada a chance to jump in and just comments, reflections on what you've heard from during the presentation, during the discussion. Um, we've got a few minutes left, so uh, as much or as little, Alec, as I turn it over to you.
Hi, David. Sorry, I'm ready to provide the closing remarks now. It cut me out for a moment.
Oh dear. Okay.
Oh, okay.
Sorry.
So we're good. So I think I joined in at the right time. So thank you
Yeah.
so much for passing it along. Good morning, everyone. Thank you for the opportunity to provide closing remarks on behalf of Global Affairs Canada for today's Global Health Financing webinar. I would like to thank all participants for engaging in this important conversation and for taking the time to learn from the work being done in the Philippines by Likhaan. On behalf of Global Affairs Canada, I extend my sincere thanks to Inter Pares and Likhaan for facilitating today's discussion and for their ongoing commitment to creating meaningful change for local communities in the Philippines. The Government of Canada, through its Feminist International Assistance Policy and 10-year global health and rights commitment, is deeply committed to advancing innovative and sustainable solutions to global health challenges. We recognize that progress in this sector can be quickly lost if long-term sustainability is not prioritized, particularly in more complex and challenging contexts. Identifying sustainable sources of financing, whether through domestic policies, donor support, or other mechanisms, is essential to ensuring equitable and continued access to quality health services for those who need them most. This is why we are proud to support the Sustainable and Transformative Action to Realize Sexual and Reproductive Health and Rights Projects, or STARS for short. The 7-year initiative, implemented by Inter Pares in partnership with Likhaan, contributes directly to the work that we heard about today. I look forward to meeting beneficiaries in the Philippines in the coming weeks and learning more about how this project is strengthening sexual and reproductive health services in underserved communities. Thank you again to Inter Pares and Likhaan for an engaging and insightful discussion. We look forward to seeing how these lessons learned continue to inform practice and create lasting impact in the future.
Thank you very much, Alec. And I look forward to traveling, meeting up with you in the Philippines shortly. It's going to be great. We'll take you to some of the communities and the clinics, and I think it'll be a really good experience, and I look forward to it. And thank you so much to Global Affairs Canada for the ongoing support. I think Inter Pares has always, as our strategy, our methodology, we believe in long-term relationships with Southern counterparts, and it has been a very long-term relationship with Likhaan, and it has been long-term and stable funding and support from Global Affairs Canada, and we are incredibly grateful for that. Um, so if this is your last chance, folks, for any questions or comments. That I don't see any more. So I would like to thank all of the participants, to thank all of you for joining. Thank you again to Global Affairs Canada. Um, Thank you, Mike and Simon, for the interpretation. Uh, Very much appreciated. There will be a recording and that will be made available to people. So please get in touch with us if you want the access to the recording, and feel free to share it with people. We're anxious that this information, this discussion get out to people. Um, Thank you for a very late night to Ronnie and June. We appreciate it. We're going to continue with our morning here in Canada. Um, and I hope that we will have further discussions on this topic and other ones as we go ahead in 7 years of stars. So thank you, and have a good night or a good morning, as the case may be.